Welcome everyone to the African Heritage Community COVID-19 Needs Assessment Presentation of Findings brought to you today by the Duluth NAACP and Healthy Alliances Matter. My name is Christina Troke. I'm a Community Coordinator for Healthy Alliances Matter, member of the Duluth Branch NAACP, and on the steering team for the Zeitgeist Healthy Hillside Initiative. I am a mother, an artist, and educator. I currently reside in Hermantown with my husband, Benjamin, and 4 children. Today, we will have 2 presenters, Janet Kennedy and Dr. Olihe Okoro, as well as commentary from 2 of our community consultants, Ms. Desiree Singer and Mr. Desmond Scott. And without further ado, I would like to introduce our first speaker. Dr. Olihe Okoro is an assistant professor at the University of Minnesota College of Pharmacy in Duluth. She is a pharmacist by training with a master's in public health. She conducts research in health disparities with specific focus on communities of African heritage. Welcome, Dr. Okoro.
Okay, so like Christina already said, I will present and then Ms. Janet will follow up. So thank you for the introductions. In terms of the outline of our presentation, I'll give a project overview, talk about the findings. We had some key recommendations from community members who participated in the needs assessment, and then we'll talk about ongoing efforts and some next steps. So in terms of project overview, before I even get into the project overview, I just want to acknowledge the partners that we had doing this work. Some of them were sponsors, and so they gave funding, they provided funding for this effort, and some also engaged in terms of the actual activities that we did, especially following the needs assessment. So here is a listing of that. I will not name all of them, but we're thankful and we do want to acknowledge them. And of course, we also had a community consultants on this project, Ms. Desiree Singer and Mr. Desmond Scott, and we will give opportunity for them to be able to say a few words later down the line during the presentation. So before I go to the findings, I just wanted to kind of just draw our attention to some of the stats. Of course, we all know that communities of color are more impacted by COVID. Some of us kind of think about it nationally, which is true nationally, but sometimes we're not thinking about it in terms of locally where we actually are. So this is from the CDC, and of course you can see that Blacks or African Americans have higher case rates, hospitalizations, and death nationally. Then this is Minnesota. This is dashboard from Minnesota Department of Health. And so you see Black Minnesotans, that's in the teal color. At the beginning, you will see the percentage that accounts for, that proportion of Black persons in Minnesota, that's about 7%. But as you begin to go down, you see that the case rate, hospitalizations, ICU, much higher, higher than the 7%. And I want to say, we all know, of course, that this is also an likely an underestimation in terms of the cases themselves, because some people, it's not everybody who had COVID that got tested. So then you come to St. Louis County, and even though our needs assessment, probably went beyond the county because we looked at just the community around us, including even Superior, but just looking at St. Louis County, you'd see that Black/African American, while you have 1.5 as the estimated population, you have the case rate as 1.8. So it tells you that, both at the national, state, and at the local level, the data is saying basically the same thing. So let's talk about our findings, from the needs assessment. It was a mixed methods approach that we used. We had a survey that was out, and then we did interviews with about 30 persons, and then we did focus groups. There were 8 groups that we had, because we wanted to cut across, all demographics. So we'll talk a little bit, I'll show you some of the demographics for what we did. So for the survey, you would see that we had African Americans well represented, but we also had African, because you have persons like myself. I'm from Nigeria. I wasn't born here in the US. And so making sure that we're, taking into consideration all the different people groups who are Black. And then you have those who are bi or multiracial, with one of the races as Black. So you would see with gender, we had, a lot of males, lots of females, kind of 1991 cuts in the middle, cuts across in the middle there. It was a median age of 42. It's skewed, but of course it was the survey was a cross-sectional survey, and it was a convenience sample. So it got to who it got to. We tried as much as possible to, push it to all the different demographics as we could. So what we did was in the interviewing and in the focus groups to make sure that we capture other demographics that may not have been fully captured in the survey. In terms of insurance, you would see 83% had insurance coverage. We still had up to 16% who did not have, and 1% said they did not know if they had or not. And this really speaks to also just knowing what's available, because we're in a state where it probably is available for most of them. So when we talk about knowledge, we'll get into that, how things might be available, but what's the accessibility? Do people even know where to go to for things that they may actually be eligible for? So looking at the interviews and focus groups, so these are the demographics. You would see that we had quite a good spread in terms of education. We also had a good spread in terms of employment. So you had different persons represented, and we actually had teens. So if you look at unemployed, if it seems a bit high, it's actually because it's some of our teenagers, some of our college age students who were not working at the time, but we wanted to hear their voices. So if you look at the focus group, you'll see that we actually had a median age of 21 and a range from 13 to 80. And I will tell you that this focus groups, especially the one with the teens, was so informational. At times we don't consider what their perspectives might be, when we're talking about, things that affect the entire nation. But oh my goodness, they brought such insight, just in terms of how they see things. So for knowledge, on the survey, we had about 8 items. We had 8 items, looking at knowledge base. And we had to toss one of the questions because it was about the availability of vaccines. And because our survey period spanned over like 3 months, at a point, there wasn't any vaccine yet. And by the time we were ending the survey, there were a couple of vaccines that were just about to get approved. So that question was not included. But you would see that it was a mean of 5 and a median of 6 out of 7 correct. So that would just give you a sense of the knowledge base. And this is complementary to the findings also from the interview and the focus groups, because we did ask them about, knowledge about COVID. And there was generally good knowledge base. It was a wide range. Some people knew the basics, and some people really had a lot of information, including even medical information that you may not even expect of someone who is just a lay person. But there was also like a variety of sources of information. And it was interesting because that was kind of associated with age groups too. So you had like older people who listened to news all the time, local news, national news. Then you have the younger people who are very much on social media, and that's where they get their information. And then you have others who are intent on sourcing information for themselves and will get on the internet and find out the information and whether it's valid or not. We did hear quite a bit of conspiracy theories around 5G network, around this being man-made and being orchestrated. And then just talking about it being something that targets the Black population to eliminate it. So we did hear conspiracy theories from a few people. So in terms of preventive behaviors, I just want to give you a snapshot of a couple of, the questions that we asked. One of the questions was, in the past 1 week, whenever I came home, whether immediately and always, sometimes never, and you'll see that most people actually adhere to, the preventive measures that were prescribed. This talked about when I'm trying to move this out of the way to be able to see the question. Whenever I go out, whether they wore a mask or not, and you also see that most people did wear their mask when they went out. There was a question of social distancing when I'm around people who are not from my household, whether they maintain 6 feet. Some people are able to, some people are not able to. And so in the interviews and the focus groups, we're able to explore that some more. If persons, like a lot of people were working in front-facing jobs, Sometimes they were not able to social distance adequately. And then there was notably participants talked about how sometimes it's really dependent also on the other person adhering to that. And some people said they actually had to advocate for themselves, to be able to push back on persons who were encroaching into that space, within the 6 feet. We asked about social gatherings, and it was quite a spread. We had the same thing in the qualitative data. Some people still gathering, some people not, and a variety of reasons why that was so. And there was the notion that it was the younger population that tended to throw caution to the wind and gather more than others. So there was just a variety, some people still gathering, some people not. We had one question on vaccine because at the time we launched the survey, um, they were already testing, and there was hope that it was going to come. We didn't know when. So we had this question on vaccine. We asked if vaccine is readily available, easily accessible, and at no cost, would you be willing to get vaccinated? And it was, you can see the spread, very interesting. 35% said yes, 26% said maybe, 27% no, and 12% I don't know. So between maybe, no, and I don't know, that's like 65%, outright no 27, that's quite high. That's again it was a survey, and so convenient sampling, we can't exactly assume that this is representative of the population itself. But I will tell you, when we get to, we'll talk about a little bit more about that in terms of the interviews and the focus groups. Let's talk about knowledge. So with knowledge, they talked about, and this is knowledge, I would say information was really a challenge, So they talked about just there being multiple sources of information with conflicting information sometimes. So sometimes you hear one thing and then you turn on the news and you hear something else, and maybe CDC saying one thing and something else, someone else is saying another thing. So conflict of information, sometimes too much information. We had that too. The layperson really just wants bite-sized information, sometimes just too much. Another key challenge was the validity of the information, being able to distinguish between what was actually accurate and what wasn't. And then the credibility of the information source. Who's the information coming from? And so when we talked with interview participants, and especially in the focus groups, it talked about, just wanting to hear from healthcare providers who are Black, wanting to hear from researchers who are Black, wanting to just get that information from persons they feel like, okay, this person represents me. And so that would help with credibility. And then accessibility of information, that was variable across the population. Some people have internet access, some people don't. Some people may not be able to access information that's online, may not even have phones, and may actually need hard copies. And how do we get those to them? Um, so that was it. And then there was also, lack of information on what exactly to do. Like, okay, so I know this is there. So if I needed to get tested, what's the procedure? Where do I go to? What do I do? Like, is there some protocol of what to do? And where can I find that? So there was, we discussed a lot with, especially in the focus groups and also in the interviews, about the impact of COVID on the African heritage community. And one key thing that really um, came forth from those conversations was that there were things that were already there before COVID. So the structural inequities, the racism was already there. And so it wasn't a COVID thing, but with COVID, that was further highlighted. And then the impact of that was felt even more because of COVID. So just talking about things like policies that were not already equitable, the types of jobs and all of that people had, economic situations, barriers with education, and I will talk a little bit more about that. Mental health was really big. A lot of people who already had pre-existing mental health conditions, of course that got exacerbated, but with not being able to gather with other people, not being able to connect with family members like they would have, and have the social gatherings that they would normally have, was really hard, especially for a community that likes to connect with each other communally. So that was really hard hitting. So in terms of even things like being able to gather in church when churches, had to close, that was really very difficult. And then, of course, it hit hard economically. As you would expect, some people lost their jobs, some people had to cut back on hours, and then some people just had to give up, the job because they had to be home to stay with their kids. So that was hard for quite a lot of people in terms of resources. I would say also that community did rally around in terms of providing and meeting needs for people. So in terms of the sense of community, that was felt even more. There was a greater sense of community. So this is what we're hearing from participants, that people were looking at for each other. Community was rallying around, trying to meet needs of individuals and families, and providing care packages and things like that. But there was also a paradox. There was also a less sense of connectedness, let me put it that way, because of the distancing and things like that. And then there was this came through so much from the younger participants, so protective of the elderly. So amidst all of this, there was just that talk of, we need to protect our elders, and that's very cultural, especially those also who have underlying conditions. So some people who are young would say, well, I mean, left to me, I may not care that much, but because of the elderly in our community, I'm more cautious, and just very protective of them. There was also, again, for some people, because it was really hard, a switch from that communal mindset to just more of self-preservation, especially for people hardest hit who had to they're just looking to survive. Then, of course, there was the education with access. So some of the parents that we talked with, it was hard for them. It was hard, especially for those who had to go to work and there was no daycare. They couldn't, pay for daycare. There was, not as much support as they could. They could have family, but you also don't want to compromise the health of your mom, or your aunts because they are elderly and things like that. So it was tough for them, and I would say especially for Black women. Let me put it that way. When I interviewed women, that narrative was right there. Like, this is really hard because you have the children, you have education. Should you go to work? Should you not go? If you don't go, how do you provide? If you are, for instance, maybe a single mom. So here I have a couple of quotes. I just want you to hear the voices of the participants and how they were viewing things. So this was from one of the focus groups, talking about how already people who are marginalized and don't have the usual access, but how some of these things are barriers for them. Everything went online virtually. So trying to download forms, complete them, especially if all your access to internet is on your phone. How exactly do you do some of these things? So I would say for some of us that work and some of us, who are in education and in healthcare, that's how we communicate. That's how we do things. You have things in your office or in your home. You can print, you can fax, you can a whole lot of things that you can do. But thinking about some people who are not able to do some of those things. So this was an interview, particularly this woman was saying Black women are hardest hit with this. That was her perception. It says the Black women have now lost their jobs and we're the ones out here left to take care of the children. We don't have a way to take care of the children. Then we're condemned and then ostracized for doing things other than for taking care of our kids. And I would say that, there was just a lot of choices for some of them to make. One of the women I talked to recently talked about going to work, trying to connect with the school to get some attention for her kids because of the education, so that they can keep up with the work, not being able to get through. And then finally they sent social services you know to investigate her, because they were like, oh, your kids are not engaged as they should be. And she's like, I've been trying between work and this, I've been trying to see how I can connect with the teachers. So it was really hard. So let's talk about testing. So testing, being a type of is part of medical care, really is prevention, but some of the barriers or most of the barriers were similar to what you would have. So we talked about testing, but we also had participants talk about medical care. Accessibility was one of the issues. when, of course, the testing sites, were up, some of the locations were drive-through. So, of course, if you didn't have a car, you couldn't exactly get tested. Some of the places were places where you needed transportation to go to. And for a time, there wasn't any public transportation running for some period of time. And so that was really difficult for people, even for taking the public transportation. When you get there, how do you navigate to that place? And if it's a drive-through, how do you engage to get tested? And then we had just willingness to get tested. So we had a lot about historical distrust. But I want to say why I'm highlighting previous experiences is alongside the historical distrust, we also had a lot of stories about current experiences that people have had in the healthcare system that has just made them very unwilling to engage unless it's something they absolutely have to do. And so we've heard that a lot. We've seen people just not you know feel like unless it's really bad, I'm just not going to go. And I've done research too, just around patient experiences, with the Black community here, and I've had that over and over again. So a lot of times we talk about historical distrust, and that is true. But I want to say, when the historical distrust is when your current experience also aligns with that, it becomes a problem more so. There was fear, and then there was the stigma, like, if I'm going to get tested, will people think I have COVID or not? And then just the lack of information. The long lines and wait time, over time, that became, better, and access improved when more testing sites, were set up, and you could actually just walk in and get tested. And there was more information readily available. Of course, having a saliva test was also very helpful. And then when people got to know that there was no cost attached to it, that was also very helpful. But we also heard from people that a lot of people did not know that, or did not have that information, and so may not have gone to test, or are still not going to test because they are just not adequately informed. So in terms of medical care, so I just want to highlight, a quote here. So this is someone saying, just that unwillingness to engage with the healthcare system. They're going to assume that I'm trying to seek out some type of medication, like a narcotic or something. They're not really listening to my issues, my concerns. They're brushing it off, telling me to go take a Tylenol or an Advil and lay down, drink some water, just the general, the basic. Once you go to the doctor so many times and you feel like you're being mistreated and not being heard, you stop going. So here, it also talked about the historical distrust. So I want to highlight some of, in terms of with the vaccine. So there's the historical distrust piece with the healthcare, and there's also the perception. There's also the perception of, will it work or not? Will it work or not? So people are like, well, I'm going to wait a little bit before I do this. I'm not sure if this is going to work. There's that skepticism, like, this was too quick. And then there was a lack of lack of knowledge around, how the vaccines work actually. So some people felt, oh, it means, let me I'll try to go forward. So let's see, this quote says, especially with a generation. So I put this quote because this was actually from college age students. And just to see how that historical distrust is still, is still something that they're very much aware of. So it says, especially with a generation, we're so in the know with everything and we're skeptical about everything. I feel like it's more about waiting and seeing if this is really it. So you see earlier, they said scientists are experimenting every day and you really don't know if you can take anybody's word. And there's a lot of government funding that goes into that and hidden agendas. So you can see there is still that piece. There is still that piece. So as much as we want a cure, want a vaccine, want our lives back, which is one of the things we were hearing, they were like, well, maybe we'll take it because we're just tired of living in fear. And so that's kind of a motivation. But they're saying, well, I also have to balance that with my health, and I just need to make sure that this is the right thing for myself and my family. So this one says, I don't think Black people will take the vaccine. I don't know about me taking it. I would want to take it, but I would want to have it really tested. Okay, so let's go to the recommendations here. So of course, we had talked about the knowledge piece. So one of the things that they talked about was just having a credible and trusted source that community can go to. So saying, okay, this is, if I want valid information, information that I can trust and I know where it is coming from. Where is that source of information? And when my co-presenters start to talk, you see what we have done along those lines to address that. They also proposed having a messaging campaign that targets different demographics. So the one clear thing that we did here was you have to use multiple strategies. And so it's something that, just sharing with all of us here, just knowing that there's no one size fits all. You can't reach everybody using the same, it could be the same, it should be the same message, but not the same media and not the same strategy. So they talked particularly about reaching the younger generation using social media platforms, having something that is fun for them that they can engage in themselves, as part of that prevention. And then also for those who are not able to access information online, having hard copy information packages, whether we mail them to them, drop them off, put them around as flyers, posters, and community spaces, but just make sure that that information is out so that even people who are not able to get online are able to get the information. Another proposal or recommendation was to have health communication from Black healthcare providers and professionals. So that is something, that we heard. They were like, okay, if I hear it from someone who looks like me, and this wasn't just about COVID, so because the historical distrust is not just about vaccination or about COVID-19 as we have it currently, but just who's communicating that information. Is it someone that I can look at and I feel like, yes, this is somebody who represents me? Another other key recommendations were around community engagement and capacity building. So they talked a lot about focusing on the younger generation too. How are we focusing on this younger generation thinking long term? Because a lot of times we're focused on the problem right now, but if we're going to solve problems that have been here for so many decades, we have to be thinking long term. So how are we building up the capacity of the youth and young adults, Black youth and young adult that we have presently? What's going on with their education? What kind of opportunities do they have? Are they moving along that trajectory, to be successful? Are we addressing the inequities that are barriers, or are we going to have the same situation 20 years down the line? Um, Another proposal, another recommendation was just having community members as peer navigators to help community members navigate the healthcare system. And so this came out of like people, the healthcare system is really very complex. Any of you that works in it knows that it is complex. How much so, for the person who is coming into it. But the thing about it is community, has culture. And so it's community members that understand how community operates and are able to help community navigate what would be the concerns. Sometimes if you're not from a specific community, you're really not aware of what may be barriers or how to engage to be able to elicit that. So we need to keep thinking about how community members can be part of systems in order, to be able to bridge that gap for community members who need to engage with that system. Funding to support ongoing community-led efforts. So a lot of times community is willing and ready to work on things, and sometimes it's just the instrumental support to actually be able to do that. And we'll talk a little bit more about that later. And then increasing the diversity of the healthcare workforce. So this has come up time and time again, even in previous research that I have done, that we really do want to see more diversity in the healthcare workforce, just through at different levels, different disciplines, and so on. So this is where, this is a quote from one of the focus groups that we had that, talked about having a campaign, that focuses on the young, on the youth and young adults. So they said, even if it's just a slogan like this, mascot backup, so that they know keep your mask on, said if you could hit social media, Twitter, YouTube, Facebook, Snapchat, just that type of stuff and reach out to them, I think that we could make a bigger difference. And than we're making in the younger generation right now. And so sometimes, we need to like think that way. How can we use, sometimes as, institutions, we don't think so much about some of these types of social media, but we have to be able to reach the younger generation, especially with prevention messages. So with the vaccine hesitancy, the key recommendation really was, how can we adequately educate community? Because there was a lot of unknown, like people just, what's the information? People just don't know much about this. So this participant said, I want to educate the Black community on the possible vaccination, what the coronavirus is and how we can help it, and how it's helpful for us. And they were saying, I think once we can all feel like we're being cared for, then we can come on board. So there's that one, there's the piece about education, and the other piece too about feeling like, okay, my life is important in this too. So a lot of questions that they had, we've also taken that into consideration in, and we'll talk about some of the things that we already have going on to address those. So coming to structural inequities, I'm going to try and wrap up real quick here. We talked about increasing diversity in the healthcare workforce. We need to just see more of Black professionals, have those opportunities. So in terms of like focusing on this younger generation, because sometimes people are like, how do we get in terms of employment? Like, well, while we're trying to solve the problem right now, can we make sure that those that are in the educational system are heading in those directions and that they have sufficient support to be successful and get in? Another recommendation was just having healthcare facilities that are run by and for the Black community. And then more equitable resource allocation, making sure that resources are going to people that need it the most, especially with things like community-led efforts, that focus on, neighborhoods that are poorer, and maybe people who have barriers like not being able to connect with internet, with education and things like that, just making sure that the resource allocation is equitable. So I've talked about this. So this should be my last slide. So another key thing to addressing structural inequities, apart from capacity building of the younger generation, I want to talk about that before I go to the first one. So this is something that we already are really looking critically at. How can we have more mentoring and more modeling that's racially concordant? And I will tell you, as a mom here in Duluth, um, I remember a few years ago, I have a son who is a junior in high school right now, and when he was in sixth grade, and by the way, I mean, we've been here, this is our seventh year in Duluth. None of my kids has ever been taught by a Black teacher. I don't know that any of them is aspiring to be a teacher because they've never really seen a teacher in front of them who looks like them. And that's where we're talking about that mentoring and modeling. So my sixth grade son at that time said, hey, mom, my science teacher is wondering if you can come in and talk about, pharmacy. And I'm like, sure, yeah, I would. I was like, my thing at that time was like, oh, this might be the last time he ever wants his mom in class anyway, and I went in and it was just so good too, because in that class, many of them had never had someone come and teach who was Black, even for the other kids there. And it was such a good experience. And in my head, I'm thinking, oh my gosh, I hope I've inspired at least one child there to want to be a pharmacist, because they saw a Black pharmacist. So those are the type of things that we're actually thinking about. So anyway, going back to policies and processes, we need to engage community, when we do some of the things that we do in terms of making policies and structuring processes. Because unless you have a community lens, you may not see how it could either benefit or harm community. I don't even need to say there's zero tolerance for racial discrimination. That is an absolute must in both in healthcare and anywhere else, And then just adopting an equity lens. Like we can't say enough about that. Adopting an equity lens. Many of us have seen this before. Or maybe a different version of it. A lot of times, so I want to challenge us. A lot of times, our policies actually tilt more to equality than equity. And I'll share. Let me share, a story with you from one of the interviews that I did. So it was the single mom that I was interviewing. With I think she had 4 kids or 5 kids, and she talked about just going to the store, and at that time it was a limit of one on a packet of chicken. And she's like, there's no way that was going to be enough. And she had to get someone to take her to the store because she didn't, have a car. And then you get to the store, and then you're able to pick up only one, but you have this many people at home. And I was thinking, and she was also saying, what if it's even a multi-generational home where you have maybe 7, 8 people in that same house? How is that? While that is equal across board, but that's not equitable because this is not enough for this family, but it is enough for some others. And so it just got me thinking, sometimes we do make policies with good intention, and it's supposed to be equal across board. But if you already have a population that has more barriers, then just making it equal doesn't cut it. So we need to rethink some of our processes. Think about even things like forms. Who is able to fill out the form? Who is able to get online? Who is able to make an appointment online? And who does that affect and who benefits from that? I am going to pause here and turn it over to Ms. Janet, who will be sharing with us the current efforts, ongoing efforts, and the next steps that we have. Thank you.
Thank you, Dr. Okoro. Next, I would like to introduce Ms. Janet Kennedy. Janet is CEO of Healthy Alliances Matter LLC Company and founder of Healthy Alliances Matter for All. Her mission is creating and building equity through policies, practices, and procedures that positively impact health and well-being for everyone. She works collaboratively with folks investing in areas that align with social determinants of health, including economic and wealth sustainability and business and community impact development. Janet brings a unique narrative to policy decisions as a Duluth City Councilor after working 25 years in the medical profession as a physical therapy assistant, director of rehab, and program director for PT, OT, and speech. She believes a community will only survive and prosper as a whole when we are all walking on even ground. Welcome, Janet Kennedy.
Thank you, Miss Christina, and thank you, Dr. Okoro. I'm excited to be here and have been able to lead the COVID response for the African heritage community. It's been a great collaborative that we've worked with our community partners and have had some funders that have supported us. It's been a great experience. I will say that running for office is a lot like organizing during COVID. It's a great amount of work doing both. I will say that this response and COVID itself has changed how we do outreach and how we continue to do the outreach. It's a lot of time, it's a lot of reorganizing, and each day it changes. And so while it's been hard work, I'm very proud to have been able to lead this effort. Next slide, please. So part of our organizing and outreach, you have heard, and hopefully you've all had an opportunity to look at our website, healthequitynorthland.org. You'll see all of this information on there. As I stated, the organizing and outreach really changed, and each day it changes. And so we have to be really adaptable in the work that we're doing, especially reaching the African heritage community who's, and I'll just say, pretty dug in, right? We spent the last year telling all of our community to stay home, stay safe. And now we're trying to tell them to come out and get tested and get a vaccination. And here's some information. Like, where are they? I mean, we really had to figure out, where are people right now after we tell them that? We really are, we're bound by being culturally specific, but this is all information everybody can use. And so I am very proud to work on organizing and outreach. A lot of our campaigns, Dr. Olihe alluded to our youth and young adult who've done some PSAs. We've done a mask up, back up, drive up. We have some hashtags that we've shared with the community, and hopefully you'll get a chance to use some of those. And we continue to do mass distributions along with St. Louis County. One of the things that we also did, along with the youth doing their PSAs and showing you sort of what it means to them to be in the middle of COVID during a time where they're growing and learning. We also did some education awareness and debunking misinformation with education or medical professionals. I do want to just take a step back and give our community consultants, Desiree Singer and Desmond Scott, an opportunity to speak. First, I'll have Desiree just share a little bit about how it worked and the work that she did with as a community consultant. Miss Desiree is a Marine veteran and a chaplain, and we're so proud to have her on this work. So, Des, you'll go first, and then we'll see if Desmond's here with us. I'll yield.
Good afternoon. Thank you for your attendance, and thank you for your contributions, past, present, and your future contributions. Thank you. I just wanted to just tell you something quick about myself. I'm currently employed with Council Ms. Janet Jackson, Ms. Janet Kennedy with Healthy Alliance Matters and Healthy Alliance for All. But prior to that, I was with SOAR. So I was able, even though there was all folks of color coming through those doors, I had the opportunity to work with the Black folks that were coming there with their reentry program and their employment program. Just having to be there volunteering with the Rainbow at the Rainbow Center. I'm still there as long as they just reopened there. Let the volunteers back in. I was volunteering at Bethel. I chaired a life issue women's weekly meeting. I still serve community with meals when they were serving hot meals. But I still literally go in the community and drop off with the River Church. Excuse me. I also had before COVID, I even had I have an application into St. Louis County. So I'm just letting you know that I'm before I joined this wonderful team, I was already in the community, and so once I joined the team, when I was out there to get information and trying to find out what's going on with them, I was able to relate to them. Not only that, because I had I was familiar with their struggles, you know, and so when I was out there, the main thing that I saw was that we're afraid, and we're afraid of the unknown, which I'm quite sure that's with all races right now, and not following through with wearing the mask, with the backup, and just getting together, even in elevators. So it's a lot of things that I saw that we weren't complying with, even with when the governor shut down, you know, the city. So that's about it. So I was able to emphasize and sympathize with them, and I'm grateful that I was able to get their feedback. I wanted them to let them know that I am a mouthpiece as well as an ear for them, and was able to participate with getting this information. So with that, I yield. Thank you.
Thank you, Ms. Desiree. The outreach for the surveys, the focus groups, and the one-to-ones Desiree and Desmond did, as well as myself, it was good to reach out to community members, and it really showed them that we were invested in them. And that's where a lot of these campaigns came out. One of the focus groups we did, somebody had stated, one of the participants came up with a mask up backup. And then it sort of drew from there. And I'll give you a little more about the other two after Desmond speaks. So Desmond is a 21-year-old who's lived in this community all his life. I believe he was born here, has lived here all his life. He's been doing a lot of work on the research project and getting youth and young adults and other community members with the surveys, the focus groups, and the one-to-ones. And now with the Mask Up Backup campaign with the youth and young adult. So Desmond, if you want to just share a little bit about the work and how it impacted you and things that you had learned.
Hello. Yeah, so I was one of the community consultants on this project. So yeah, starting off, I was doing a lot of work on the surveys. So one of the things I had kind of focused on was trying to reach people around my age. So for me, that looked like a lot of like texting, sending people emails, and then also sending people messages on social media. So I had gone down my friends lists on Instagram and Facebook and messaged everyone individually asking them if they'd be interested in taking this survey. But one of my favorite things that I noticed from this project, or one of my favorite things about it, was noticing the things that people were telling us versus things that we had to kind of observe and recognize ourselves. So that ended up resulting in a lot of adaptation and thinking on our feet, like Janet had told us. So after a while of sending out those messages to people on social media and maybe not noticing as much feedback, we had to kind of think about, okay, what are some other things we can do to get involved? So I had to go from mostly doing stuff on social media and texting and on the internet to doing more in-person events. So for me, that looked like maybe going down to some of the mask handouts downtown, or events up at UMD to talk to people face to face. And then I also know Family Freedom Center had done a drive-through barbecue, and I was there with the iPads that we had for people to take the surveys on. And that was another way I had gotten out into the community to work on this. Yeah, some other things I noticed, especially with people my age, was that social interaction piece. It definitely seemed like a lot of people were very interested in like wearing their masks and socially distancing, but they still also wanted to be with other people. And that was a very hard thing for a lot of people. So something I'd noticed was it started off with people wearing their masks and keeping that distance, but as their evening or whatever went on with their friends, they get more and more comfortable and kind of become more lax with those preventative measures they were taking. So that was one thing. After I had done a lot of that work on the surveys, I moved towards interviews and the focus groups. So I'd helped get people for the focus group. So found some young people to be involved, and I was actually part of the youth focus group myself. So that was a very good experience. And then once we had the interviews and they were transcribed, I also helped with taking the information from the interviews and putting them into a spreadsheet, so we had all the information in one place. And just from reading through the interviews, it was very insightful seeing what people had to say. Yeah, and then more recently, I've just been working with the Mask Up Backup campaign.
Thank you, Desmond, for sharing that. And we look forward to continuing this work. You will see on this screen, I'm going to switch over to the next one soon. What came out of that are the hashtags that are really important, as well as the education and awareness, debunking information. We'll talk about that. So next slide, please. Here is one of our flyers. We've had several flyers that have come out. We're very proud of our partners as well, who we'll see later. But you can see that we've used different sorts of media. This one has been printed and continues to be printed and given out within our packets if we're at events. I just want you to know that we're really taking safety measures when we're at these events and what that looks like. But we have the hashtags. We've done Twitter, Facebook. We're trying to get folks to TikTok. And so if you see this poster and this hashtags, please join in with us. And let's go to the next slide. Throughout our work, we've been listening to the community and looking at the different medias of how we can create education. Part of the Mask Up Backup did evolve into the Mask Up Backup Vax Up. And you'll see our little logo around town. We have stickers and we have bags and we have many things that we're giving out to people just to connect with them first, and then help them feel comfortable about what actions they need to do to take to be safe. So the first video we're going to show you here was recorded. These are some of our youth and young adults, and many of these youth and young adults are African heritage, multicultural. And so we'll play this PSA. All of these are on our website and on our YouTube page, so we'll be sure to get you that. But we did want to share this one and then a medical professional video as well. So please play the video. Thank you. We are so proud of our youth and young adult and the folks that have helped them. Dance and Creative spent a lot of time, and it's just wonderful to get them involved. And these are our future leaders, our future doctors, our future pharmacists. And we want to engage them in what's going on with COVID because it's their life as well. There are 2 more videos, and so I hope you take the time to actually watch them. Next slide, please. So we did also, as I had stated, we engaged with the health professionals of African heritage, and we had talked about how do we continue that work because we need to continue this foundation. What we don't want to see is we're going to invest all of this for African heritage people and others of color, and that it goes away. We need to continue this work, and so part of the conversation with medical professionals is helping to debunk misinformation and allowing people to feel safe to actually engage in getting a test and getting a vaccination, or just debunking some of that misinformation that's been going on for the past year. So next slide, we'll show another video here.
I've been talking with community members and hearing a lot of skepticism concerning the vaccines that have just been approved. And there's a lot of reference to historical events. And so I was wondering whether you could speak to that. Why are people skeptical, and what is it about the historical distrust that persons of color, and particularly of African heritage, have concerning vaccinations?
Well, people of African heritage have a great distrust of the health system in general. The health system is an institution, and we know that within our institutions, there's racism. And we've seen this from time immemorial. So we know one of the first incidents is the Tuskegee incident. That was in the 1940s all the way to the 70s. And to show you how relevant it is, my grandmother's hairstylist had a father who contracted neurosyphilis, and we're talking in the 70s and 80s. So in my generation, there are people who existed amongst me in Birmingham, Alabama, who were victims of this experiment. We also know that even before then, during slavery, Black and African heritage bodies were used in experiments. J. Marion Sims, who's known as the father of modern gynecology, did experiments on slave women who had sustained birth injuries in childbirth. And so those women were operated on without the benefit of anesthesia and any type of antibiotics or any type of privacy. So our bodies have been used and abused. That's why we have so much mistrust. And we can even go to the Army, in which the Army used Black military personnel in experiments to see the effects of mustard gas on skin. So we can go all the way through these historical events, and it's reason enough for us to give pause as to, do we trust anything coming out of the health system here in this nation?
Thank you for that.
So what would you say to those who right now are skeptical, because they do have reason?
Do you want me to keep going, Janet, or do you want me to
we can stop there.
Okay.
Thank you. I want to give
Okay.
some time for questions here. Thank you. Again, the videos are on the Health Equity Northland website, as well as Health Equity Northland YouTube. And this is where we started to get into the mask up, back up, vax up. This actually came from conversations with our partners, and a doctor had used that term, and we were really like, this is really great. We want to progress our mask up, back up, twin ports to mask up, back up, vax up, because that's when the vaccine started coming out. So we're really excited about the campaign. And then again, watch the videos on our YouTube or website. Next slide, please. So here is the website. We're so proud to launch this a couple of weeks ago. It's still growing. You can see that we have a place where we're sending people to go for information. We're updating it with testing sites. We're updating it with vaccination possibilities. And as well as there are some activities where people can get hired. There's a place to contact us. This is a general place where people can go, because that was part of the conversation. There was nowhere anyone could go to find out this information. If you look at this this logo here, it's actually a heart with a bunch of people's hands. We can't see the top. And then in one of the places, our mask up, back up, backs up smile face is in the middle of the hands. You'll see that once in a while. So check out the website. Next slide, please. And that is the end for me. I'm excited to be a part of this program, and I will turn it back over to Dr. Okoro.
Thank you very much, Ms. Janet. So what message really do we have for you? The key thing is, I don't know, all of us here were from different systems, different institutions, agencies, and so on and so forth. And there are ways that you can engage with community and be more supportive, of the Black community here. So one of the things, the last thing I talked about was just using an equity lens in terms of our policies and processes. And that's, one thing to be able to do that really, because we all have blind spots. To be able to do that, there has to be sufficient engagement with community and to ensure that community voices are part of what's shaping policy and also shaping the processes that we have in place. So we would want to ask that you do seriously consider, ensuring that you have community voice. And it's not just asking someone from the community to come and be a part of it. We really need to think long term about how community can also have, can also have ownership. Because what we were hearing, for instance, from the interviews and the focus groups, there was always that reference to system as they and community as us. And so you can see that a lot of people don't feel like they have any ownership, like they are part of that system. And so we have to really think about what our recruitment looks like, what our capacity building looks like, what our training looks like. Are we ensuring that persons, from these communities that seem to have more impact, especially with health and other things too, that we're supporting community members enough to ensure that they're on track to get into some of these places. And when you're thinking about processes, what works best for community is community that knows best. I will tell you that one of the best things that, most effective things that we did was having community consultants on this needs assessment. I'm not even sure what I would have done. I don't know who are you going to get to and how do you get to them and what are the challenges, what are the barriers. Community knows best what works for community. Secondly, just talking about using that equity lens, rather than something that's equal, make it, equitable. And I would talk about, for instance, with vaccines, we have the policy right now. So you would have, okay, 65 plus and above to get the vaccine at this stage, but you have a group that's more impacted. Why would we apply the same thing? Now, in where we are now, what we even need to ask ourselves is how many people from the Black community are 65 and above? So when you cap it at that, how many people are actually able to get the vaccine? And so you continue to delay, and so you continue to have more impact. Those are some of the, I will invite Christina to speak more to that, and perhaps also talk about just funding support, for community-led initiatives, because community is able to, from what Ms. Janet was sharing, you can see that a lot has been initiated already, but we also need instrumental support to be able to continue to move that forward, especially on the long term. Christina, I'll turn it over to you.
Thank you, Dr. Okoro. I just want to say, with partnership with St. Louis County, ACO, NAACP, and other health agencies, we were given the opportunity to participate in a vaccine clinic for Black and Indigenous people of color ages 65 plus. Our Mask Up, Back Up, Backs Up team spent a few days making phone calls and fielding questions from our community elders. And we're happy to say that the clinic went very well. We were able to distribute approximately 40 tote bags filled with educational materials, hand sanitizers, and masks. Culturally speaking, greeting our elders, many of whom have been isolated this past year, was an honor for us. So we're very thankful for that opportunity. But like Dr. Okoro said, there were a couple of barriers that came up in this process. And she had already mentioned the one where we have many people of our community who are in that 50 to 65 age range who have risk factors like diabetes, asthma, hypertension, identified COVID risk factors that we were unable to serve during this clinic. And then we also came into an incident where one of our elders could not get the vaccine because the pre-screening questionnaire had a question on there about monoclonal antibodies in plasma products. It didn't have that on the pre-screening, so he showed up to the vaccine clinic and then was asked that question. He attempted to contact his healthcare provider to find out if he had received that during his stay in the hospital when he did have COVID infection, and he was refused answer over the phone. And you know, it was just a minor roadblock and a barrier initially, where they said that he just needed to fill out a form in order to release his information to himself, and then fax that back to the clinic. Well, the clinic ended up not sending it to for almost an hour. So he drove over to his clinic to try to get the form filled out, and he ended up missing the actual vaccine clinic and didn't get his vaccine. So, you know, we need to, during this time, we need to figure out ways that we can serve the community and make exceptions when there are, you know, extenuating circumstances such as vaccine clinics. It was very disheartening for me. It was painful for me. I'm sure it was painful for him. And I felt as though, you know, as a community health coordinator, I felt that I had failed him. And so I really hope that in these discussions, when we're talking about equity, that we can create a way to reduce systems to reduce these types of barriers that come up in helping serve our community.
Thank you very much, Christine. I just want to remind everyone who is still on, we do have a link there so that you can connect with us. There's a Google link there for submitting interest in getting involved. And so if you have questions, I will have to go through the chat again to see. Yep. Okay.
Sweet. I believe Mary and Kay have collected some questions. So did you?
I have, thank you. And thank you everyone for the questions and suggestions you've submitted. We're just going to pick a few with the time that we have available. And the first question was that I'm going to highlight was posed by Andrea Gelb regarding because life expectancy is different depending on group and zip code, is there a move to push, you know, to give pushback on the age 65 qualification?
Well, that is a question that, you know, has to be up to, you know, policymakers in the healthcare system or, you know, at whatever level. But for sure, those are the types of information that we feel needs to be taken into consideration for sure when you make a policy. Those variabilities, you know, depending on zip code, depending on, so we're pushing back, but, you know, basically we are pushing back, but, you know, what is it going to result in? But thank you for that note.
We did have quite a few comments throughout Olihe's presentation, just people really resonating with the information that you were sharing. But there was also a few, I guess, ideas around creating opportunities for BIPOC populations to get more information about medical training using the community school model. We have our Duluth Community School Collaborative, so there was lots of interest around that and really working on that. And several people had made comments about that. So I think that might be some follow-up discussion. And then also there was a question about how can white public health, healthcare, and recovery personnel better serve the African heritage community, and a few suggestions came through the chat. So we can certainly kind of summarize those and get back to people, but I wanted to also give you a chance, Olihe and Janet, to comment on that.
So thank you for that. So from my perspective anyway, I love the idea, you know, of the education and training, that's really great. So the question of how can white professionals and, I mean, you need to engage with community. I would say it's community that knows what community needs. So that's the thing. There has to be engagement. And I want us to kind of consider thinking long term, because if you then have Black public health professionals from the community, you know, just using the model like Desmond that grew up here in Duluth, you know, so you can imagine that with engaging with something like vaccine and our elders, these are people who are like uncles to him. These are people who are his, you know, some of them even mates with his grandparents and things like that. He knows them, they know him, you know. And so if there's someone they want to reach out to get information, and he is in the public health system, for instance, that it's easy for them to just get to him, and they know he has that information and he's able to help them navigate that. So I would say that much as we can help, I think we really need to think long term about how, you know, we can have more faces in the spaces, because that's what's really helpful. We can't continue to work on how can we help, how can we, community has people and resources within them to be able to cater to the needs. How can we build more capacity is what I would say, and ensure that the roadblocks are removed and the barriers are removed to ensure that persons who are interested in the health disciplines and persons that they are actually able to get through, because they have a lot of odds that are stacked against them. So that would be, you know, what I would pitch to us. Thank you very much for that. Yes, we would really like to acknowledge everyone, our funders, our partners. We are so grateful, just so that everybody knows it's not work that's done in isolation. There are a lot of hands on deck to make this happen.
Are there any further questions in there, Mary and Kay?
I think that's about what we have time for.
Okay. Well, I want to thank Dr. Okoro, Ms. Janet Kennedy, Ms. Desiree Singer, Mr. Desmond Scott, as well as Mary Rapps and Kay Allen for helping to put this presentation on. And I want to thank all of you who are here today. There will be follow-up and future conversations. So please keep a lookout for an invitation or check our website at www.healthequitynorthland.org. Thank you.